Good morning. I'm Michael McGinnis from the Institute of Medicine. It's my pleasure to welcome you to the release of the IOM report, Best Care at Lower Cost, the Path to Continuously Learning Healthcare in America. I want to start with just a few logistics for today's session, beginning with, please turn your cell phones off. Secondly, here in front and in the front row. In the front row is Dr. Harvey Feinberg, President of the IOM, who will be coming up to offer introductory remarks in just a few minutes. To my left is Dr. Gail Castle, a very distinguished infectious disease scientist in the nation and a retired Vice President for Scientific Affairs and Distinguished Lilly Research Scholar for Infectious Diseases at Eli Lilly and Company, a committee member. To her left is Dr. Craig Jones, a pediatrician and director of the Vermont Blueprint for Health, also a member of the committee. To his left is Dr. Mark Smith, the chairman of the committee and the president and CEO of the California Healthcare Foundation. To Dr. Smith's left is Dr. Rita Redberg, an internist, professor of medicine and director of Women's Cardiovascular Services at the University of California at San Francisco, and also editor-in-chief of the Archives of Internal Medicine. And to her left is Dr. Bruce Ferguson, a cardiothoracic surgeon and professor and inaugural chairman of the Department of Cardiovascular Sciences at East Carolina University. These individuals are representing the full membership of the committee, which is listed in your briefing materials in your packets. I'd also like to acknowledge that in addition in the room are the IOM staff to the committee. Several IOM staff are here. I will point out in particular only those who spent most of their time working with the in support of the committee. First, study director, Dr. Robert Saunders, here to my right in the front row. Dr. J.D. Lee Stuckart, who's behind Rob there. Julia Sanders, who is somewhere in the back of the room there. And not here, but who I'd like to mention as well because of the time he put into it, is Brian Powers, who left us and went to Harvard Medical School. But he devoted a tremendous amount of energy to the work as well. There are hard copies of the report here, which I hope you've picked up on your way in. They can also be accessed afterwards on the website at www.iom.edu/bestcare. We're also pleased to report that the meeting today is being webcast so that additional people can join us. The recording of the webcast will be available afterwards as well. Today's event will start with welcoming and context-setting remarks from Dr. Feinberg, followed by an overview of the report by committee chair Dr. Smith. And after Dr. Smith's comments, there will be a panel conversation among the committee members moderated by President Feinberg, and then followed by a Q&A session for the general audience, including those who are participating via webcast. During the Q&A session, several IOM staff will be available with wireless microphones, so if you wish to ask a question, please raise your hand and identify yourself and your affiliation. Those on webcast and those listening can also ask questions using email, either through the webcast page or by emailing V. Rohrbach, R-O-H-R-B-A-C-H, which is noted in the materials at nas.edu. And please include your name and affiliation in the body of the message. Finally, to follow on Twitter, please note hashtag BestCare to access the Twitter feed. I think that completes the introductory and organizational details, so I'm pleased now to introduce the President of the Institute of Medicine, Dr. Harvey Feinberg.
Good morning, everyone, and thank you so much, Michael, for your introduction, but also for your leadership at the Institute of Medicine on this issue over such a sustained period and in such important ways. It's really a pleasure for me to have this opportunity to greet all of you and particularly to share in the introduction of this report. It's a very important topic. It's a subject that deals centrally with the core dilemma of the U.S. healthcare system. How is it possible that we spend much more than any other country on healthcare, either per capita or as a fraction of GDP or in total dollars, and at the same time, we do not attain the results in health outcomes and performance that others are able to achieve? How do we face up to that reality? How do we come to grips with it? How do we change it? That was the task assigned to our committee, and it's a task that the American people understand needs to be taken up. In a recent poll by Research America, 77% of likely voters said that they would support research that would improve the efficiency and effectiveness of the healthcare system. We're in the midst of the high political season, and actually both party platforms speak to this very same issue. The Republican platform states, and I quote, "We support federal investment in healthcare delivery systems and solutions, creating innovative means to provide greater, more cost-effective access to high-quality health care." And in a similar vein, the Democratic Party platform says, "We believe accessible, affordable, high-quality care is part of the American promise." The challenge we laid before this committee was how do we convert that promise into reality. The committee had the advantage of building on years of background work, discussion, animated exchange at our forum, which we called the Value and Science-Driven Healthcare Roundtable at the Institute of Medicine, led by Michael and the same staff who were introduced as the leaders behind this report. But none of this would have happened without the dedicated leadership, the concerted care, dedication, and initiative shown by the members of the committee. And I just want to say to each and every one of you who are here representing the committee how grateful I am on behalf of the Institute of Medicine and more broadly on behalf of the needs for health in America for the work that you have done. You are showing the way that America can achieve a healthcare system that is one that improves on a continuing basis, something that we call a learning healthcare system. To discuss how this can be accomplished, not simply why it's so hard, but what the solutions are. I know you're as eager as I am to hear the conclusions and recommendations of the committee. And for that, I'd like to turn now, if I may, to the chair of the committee, Dr. Mark Smith, for his introductory comments. Mark, the floor is yours.
Thank you, Harvey, and good morning to everybody. Good morning. Let me start by thanking my colleagues on the committee, those here and those not here, and particularly the staff that did such a great job in helping us. It's been a long time working on this report. So I'll get to it. I'm going to cover the highlights. Those of us who are here are glad to answer questions, and there's a lot, I think, there. Sorry. Do you want to help me with this? Ah, got it. You've seen a list of the committee members. I want to point out how broad and diverse this list is. We have people from academic medical centers, from pharmaceutical industry, from nursing, from integrated systems, from group staff model HMOs. We have people who are internists and surgeons and pediatricians, people who have great expertise in patient empowerment and engagement. And that's part of what made this work both so exciting and, frankly, so difficult, because the job of a consensus committee is to get to a place where we can all agree based on the evidence that exists with careful review. Our charge was to consider the urgent and longer-term actions necessary to foster the development of a continuously learning healthcare system. We were asked to define the foundational elements of this system for care that's effective and continuously improving, and also to define the foundational characteristics of a system that is efficient, delivers increased value, and is continuously innovating and improving in its ability to deliver high value to patients. One of the questions that I get asked by my family and at the ball game and on the plane is, so why now? There have been a bunch of IOM reports, and we actually grappled with this question at some length and said there are really two issues at stake. One is the cost, a problem well known to all of us, but part of what's new about this report is our attempt to grapple with the issue of complexity. The complexity of healthcare, both in its biomedical and organizational aspects. And in our view, trying to both acknowledge this complexity and come up with ways of dealing with it, both for individual clinicians as well as clinician organizations and for patients, is part of the path forward. As one measure of complexity, it's worth looking at how many journal articles get published every year. Now, 800,000. And one of the themes that you'll see throughout the report is that healthcare now must be a team sport. The amount of data that's available, the amount of information that comes at clinicians of all types is simply too much for any individual to handle in his or her head, or for any organization to handle without a systematic approach to how it gets analyzed and used. A few examples of clinical complexity. Physicians in private practice interact with as many as 229 other physicians in 117 different practices just for their Medicare patients. Some of this interaction is literally early 20th century, like on the telephone, and late 20th century, like faxes. Who uses faxes anymore? ICU clinicians have 180 activities per patient per day. And with regard to chronic disease, a fact of life that will become all the more prevalent as our population ages, a 79-year-old patient with osteoporosis, osteoarthritis, type 2 diabetes, hypertension, and chronic obstructive pulmonary disease, and there are many such patients who have this constellation of diseases, can be on up to 19 medications a day. This is part of the circumstance that faces individual clinicians and patients with the increasing capacity of modern medicine to do things for people and to prevent diseases that just a generation ago we would have thought of as part of, quote, normal aging, unquote. The cost problem is well known to us all. For 31 of the past 40 years, healthcare costs have increased at a greater rate than that of the economy as a whole. Healthcare costs now constitute 18% of U.S. GDP, much higher than any other country in the world. And a 30% increase in personal income for Americans over the past decade has been effectively eliminated by a 76% increase in health care costs. It would be one thing if we were getting good value for this money, but there is ample evidence, noted in the report, that there's tremendous waste in this system by the calculations of the Roundtable in several different ways on the order of $750 billion. The result, a couple of markers for the wasted opportunities in American healthcare. Less than 50% of elderly patients are up to date on clinical preventive services. Elderly patients with comorbidities require up to 19 medication doses a day. Every year, the average elderly patient sees 7 doctors across 4 practices, often with little or no explicit coordination. You've seen how complicated care in the hospital can be. The average surgery patient is seen by 27 different healthcare providers during his or her stay in the hospital. And unfortunately, 1 out of every 5 will come back to the hospital within 30 days of discharge. Less than half of non-surgical patients follow up with their primary care provider after discharge. These are just a few of the markers of places where our system can and should be doing much better. So, healthcare is based on science. Unfortunately, we have lots of science whose results are not poorly managed and turned into usable evidence. And unfortunately, even where we have very good evidence, that evidence is quite poorly used in taking care of patients, and even worse, the care of patients is all too infrequently turned back into knowledge to inform further development of scientific knowledge. In my preface to the report, I note that in many ways, the problem with learning in our system is analogous to the problem of quality. As the IOM pointed out 12 years ago, we have side-by-side overuse and underuse. And with regard to learning, we have side-by-side rushes to implement therapies that have been ill-studied and not well validated, on the one hand, side by side with our inability to do simple things like hand washing that we've known for over 100 years can prevent infection. So what's the vision? And in some ways, what makes us think that we have the capacity to address this problem, given that many of these problems with quality and cost and consistency have been pointed out before? And the committee came to the view that there are 4 new tools at our disposal that were not at our disposal even 12 years ago when the Quality Chasm into Error is Human were published. And it's perhaps some sign of how times have changed that we can use the words IOM and hashtag in the same sentence. What are the new tools? 1, computing power. That's really beyond what anyone could have imagined even a generation ago. Computing power that is ubiquitous and affordable. Second, connectivity. The fact that we have not only enormous computing power, but that providers can be connected to one another, providers can be connected to patients, and patients can be connected to one another, relatively simply, without great technical acumen, in a way that, again, was unthinkable a generation ago. Third, improvements in organizational capabilities, essentially management science, lean, Six Sigma, patient smoothing, some of the lessons that have been learned by leading organizations about how to get waste out of their systems and optimize the resources they have at their disposal. Lessons that have made the leading systems really shining lights over the last decade in the application of industrial engineering and other management techniques that are routine in retail and airline travel, but are still relatively novel in healthcare. And fourth, teamwork, collaboration between teams of clinicians and between clinicians and patients at a level that would have been unthinkable a generation ago, largely based on the presence of computing power and connectivity. And so the committee's view is that there are new things in the world, that these things are the foundation for our being able to tackle these problems in new ways, and that we should be actually quite optimistic that in each of these areas we can point to actual real-life health systems and organizations that are leading the way in what's possible for a vision of a new learning healthcare system. So our sense is that the system must learn continuously, that patients, clinicians, and the communities in which they both reside have to be part of a constant circle of the generation of evidence and the capturing of information from patient care that can then be returned to scientific knowledge. We have several instances in the last several years of our being slow to understand the impact of devices and drugs that we need to be capturing information on much more quickly and efficiently than we do now. We were asked to consider the characteristics of this system, and there are 4. 1, science and informatics, which means to us real-time access to knowledge for clinicians and patients, and the reverse arm, digital capture of the care experience for the enrichment of the next round of scientific knowledge. Second, patient-clinician partnerships with engaged, empowered patients, and we'll talk more about that later. Third, incentives. Most of us do what we are provided incentives to do. The healthcare system, for the most part, has incentives to do things, to perform procedures, to generate visits, rather than to produce health outcomes. And so it's the view of the committee that, much as in other industries, rapid learning leads to market success. Healthcare systems that are able to apply the best knowledge and deliver the best value ought to win in the marketplace of competition for patients. And lastly, culture. When we looked at the leading organizations that are kind of the pioneers for what this system might look like, several of which, by the way, are represented on the committee, in every single instance, one can point to bold and consistent leadership that has taken the organization in that direction. We think both within these organizations and more broadly within the healthcare system, one cannot underestimate the importance of culture, a culture of learning, a culture of support for clinicians in improving their practice. So in each of these areas, we have some more detail, which I won't go through in all of the text, but you'll see it in the report, in this table. And I want to finish by talking about the foundational elements that we were asked to talk about for each of these areas. Foundational elements, care improvement targets, and the policy changes that are necessary to implement them. First, digital infrastructure. There are a number of efforts underway, both by the public sector and by lots of increasing private collaboration, to improve our capacity to capture clinical, delivery process, and financial data for better care, system improvement, and creating new knowledge. It is still, unfortunately, the case in much of healthcare that if you want to do a research study on something, you have to construct a new, a la carte, purpose-built data capture and management system. It's called an NIH grant. And once the study is over, you shut that system down and nothing is left, and you go back to asking the next question and constructing the next purpose-built a la carte system. That obviously can't go on. If you want to find out how well you're doing in care, you construct another purpose-built, data-driven system. That's an ARC grant. And you collect the data and you analyze it, and when the study is over, you shut that down and go back to what you were doing. So our vision is that in the end, we've got to have a digital platform in which care and quality improvement and research can all be done on the same fundamental infrastructure, just as is the case in virtually every other industry. This data utility, our capacity to streamline and revise research regulations to improve care, promote the capture of clinical data, and generate knowledge, requires the confidence by patients that their data will be well handled, that their confidentiality will be protected, and that their data will be used to improve their care. And as you've heard from Harvey, the vast majority of patients are willing to provide their data for those purposes, given that those things are done. Second, care improvement targets. Clinical decision support. We've given you some examples of the enormous complexity that faces clinicians every day, not only doctors, but pharmacists and dentists and other people. It's not good enough for the answer to be in a journal that you might read later on that night when the patient has already gone home, or for you to get it in a CME course a month after the patient has already had their procedure. We have to find ways to provide real-time, on-the-spot, point-of-care decision support so that clinicians can use the best evidence to give patients the best care. Second, patient-centered care, a much-used phrase. But the involvement in patients and their families in decisions regarding health and health care tailored to fit the individual preference. There is still much of medicine in which patient preference, rather than some black and white scientific determination of superiority, ought to rule the treatment taken, the path taken. But too often we don't have mechanisms for either knowing what the patient-centered outcomes are or being able to involve patients and their families in their decisions. And lastly, community links. Perhaps the most striking example is the current effort to reduce the rate of unnecessary rehospitalization of patients who are discharged from the hospital. The only way patients can be kept out of the hospital is if there is a robust system supporting them out of the hospital, which means the hospital has to talk to people who aren't in the hospital to keep them from coming back to the hospital. But in that and many other ways, there has to be much greater integration between what are still, unfortunately, silos of care between inpatient and outpatient, between different institutions, and trying to integrate the care of patients over longitudinal periods of time for their both clinical and financial outcomes. Care continuity, improving coordination and communication within and across organizations is something that anyone who's had more than one doctor will appreciate. And optimized operations. Several of our committee members either preside over systems or have done the original research that demonstrates that complicated institutions like hospitals, by applying some basic principles of management science, can dramatically improve their efficiency and actually avoid building new facilities by making greater use of the facilities that already exist. So continuously improving those operations to reduce waste, streamline delivery, and focus on activities that improve patient health. The policy environment that's necessary for this starts with financial incentives. As one of our committee members said, you don't have to pay or make sure that software engineers go to a yearly conference to make sure they're up on the latest web design techniques, because the companies that have the best web design techniques will get the best business. We need to have a financial environment in which providing high-value care is rewarded by payers, and that reward requires that their delivery of high-value care be known to everyone. That's why transparency is important, rather than reputation. And lastly, again, the policy environment requires broad leadership from a variety of sectors, public and private, from those who train and license physicians, to those who pay health systems, to those who are responsible for so-called scope of practice of which health professional does what. So there's more on almost all of these points in detail in the report. I'm going to sit down, be quiet, and let Harvey ask some of the other members of the committee for their particular thoughts in areas of their own background and expertise, and we'll look forward to your questions and comments. Thanks, Harvey.
Thank you very much, Mark. To start off this conversation, Bruce, I wonder if I might begin with you. You're the leader of a department of cardiovascular sciences. You're a practicing cardiothoracic surgeon. What does the committee really mean by this idea of best care? Are you doing something other than just asking practitioners to figure out ways to do more with fewer resources? So I wonder if you could comment on that.
Thank you, Harvey. I think most physicians would agree that we are already at the point where we are being asked to do more with less, and the more ask is getting greater, and the resources to do that become less and less all the time. The committee outlines in the report many of the complexity drivers that are creating that kind of a situation, complexities that are organizational, they're administrative, they're personal, and I think one of the most important components of the report is to really highlight the knowledge complexity that we are finding ourselves in, where it is quite impossible to keep up with the literature, even in our own little specialty, much less to know how what we do is going to impact on a patient who has these other disease processes. And given this unsustainable reality, that the committee's work came to the conclusion that the only option was to significantly change the environment and the systems in which we as providers, along with our colleagues, can practice. Mark outlined the committee's vision and articulated that very well, and the recommendations of the report suggest how to create these systems that address these complexities with the new tools and resources that we didn't have before in order to be able to address these issues in healthcare. The idea of working as a team of providers instead of an individual practitioner in these new systems to create best care for our patients at a lower cost, where best care is really the best knowledge brought to the individual circumstances that are really important to that particular patient, their family, and their circumstances, delivered in a way that will generate sustainable improvement in that patient's well-being over time. And every time we do that, we learn from what we've done and take that information back to improve the overall value of healthcare.
Well, thank you very much, Bruce. Let me turn to you, Rita, if I may, next. I mean, you're a professor of medicine. You edit a leading medical journal, the Archives of Internal Medicine. Can you comment on whether and in what ways, how seriously do we have the combined problems of wasteful care, harmful care, and ineffective care? Are those really all the different facets of the same set of inappropriate practices? And how serious a problem is it?
Well, thanks, Harvey. I think it's a very serious problem. I mean, as you mentioned and Mark outlined, we have the highest healthcare costs. We spend 17% of our GDP on healthcare, way more than anywhere else in the Western world, and that we don't have the kind of results, the best quality care to show for it, and we have more uninsured than anywhere else in the world. So clearly we have a problem with not getting good value for what we're spending in healthcare. And when you look at it, a huge chunk of that is just what you said. It's wasteful, inefficient, and inappropriate care. And I think, you know, we really went through a lot of work to outline what was driving that and what we could do to change that in this report. I mean, in terms of the magnitude of the problem, I mean, healthcare is a big part of our federal debt issues. It's starting to crowd out education and other public services in the budgets of every state. Healthcare is just become a major issue for small businesses. It's hard to maintain the cost. We are concerned that it's clearly, I think, unsustainable at its current growth, its current trajectory. And in some ways, we're the victims of our own success because a lot of what's driving it is new technologies. We have a lot more new technologies, a lot more treatments now than we did 30 years ago when I graduated from medical school, and that's a great thing. But we've also exceeded our own science and ability to evaluate them. And so we have, because we didn't have, I think, so much technology 30 years ago, we didn't have the same need to be doing so much evaluation. Now we have so many choices that it's really important that before we start applying these in a widespread way, we know that they're actually helping patients. And in the Archives of Internal Medicine, my journal, we highlight in the Less is More series areas of healthcare where there is no known benefit and definite harm. And unfortunately, there are a fair number of these when you start to look around, and that's clearly waste in the system that if we are able to, through better science and better learning healthcare system, eliminate those practices, patients are better off and the system is better off. And certainly it saves money. We estimated $750 billion in waste in 2009 in healthcare. But it's not just about the money, it's about better care of patients. I mean, nobody, I think, really wants to have a procedure or a treatment that's not actually helping them and could hurt them. And so I think the committee recognized that eliminating this waste really requires individualized patient care, making sure that doctors have the right information at the time they need it, and that we also have the right incentives so that they're aligned to give the best care at the time we need it. And by making sure, I think the key lessons that clinicians have the best evidence, then we will be able to certainly reduce or eliminate overtreatment. And it really does depend on the science as we outlined in the report.
Thank you very much, Rita. Craig, maybe I could turn to you next. You come at this as the director of the Vermont Blueprint for Health, which is one of the most innovative state-based efforts to enhance the coordination of care for citizens throughout the state. I wonder if you could comment both on the role of states and state-based enterprise to improve the system, and particularly if you could offer a perspective on the role that patients or citizens play in this process of an improved healthcare system that does better and costs less.
Sure. Harvey, thank you. States have a tremendous role in this, and I think many of the pressures that led to the need or the call for this report are the same ones that have driven states to undertake broad-based reforms. And I think one of the strengths of the report is its comprehensiveness, that it calls for a very broad range of reforms that are needed in order to have a truly learning health system. There are states around the country that are undertaking many, or some cases all, of the types of reforms that are called for, and you can feel that there's a strong need for this, and states certainly can help lead the way. But just by the size of the report, you can feel what the complexity of this is. And in the end, there has to be a focus back on patients, on people, on families that are going to receive the services that hopefully come out of this learning health system. And that really is a critical part. And so now, so often we're in an environment where there's pressures for short visits, and somebody goes in for, a 10-minute office visit, and there's a short set of questions that are asked. If somebody has asthma, they ask them how about their symptoms, if they're using their medicines, and it all sounds good, and you get a refill of your prescriptions and you go. In a different world, it may be very different. It may be a mother and a child, and instead they're asked about their goals. What is it that child wants to do? What is the goal of the parent? What's the goal of the family? And that would lead to a deeper set of questions. And maybe you find out that superficially things sound well, but when the child's really asked, they would love to run track, and they don't. They avoid doing the things that bring on their symptoms. So it sounded good because it wasn't centered around the goals of the child and the family. And that leads, in a reform system, that leads to a plan that'll help the child meet its goal. Maybe the information moves seamlessly to the school nurse and to the coach, who have to be part of this team to help take care of and improve the life of the child. And you really have the ability to focus health services around the needs of patients and families. And in the end, the complexity of this should be oriented to a system where we can meet patient-centered and family-centered goals. And I think for our vision, and Vermont's clearly an example of that the complex changes that need to occur will occur, but in the end, it's going to be oriented around goals that are of patients and families.
Thank you very much, Craig. Gail, let me turn to you next, if I may. You have a remarkable career in academic terms. You've written literally scores of scientific papers, and you also have a very deep perspective from industry, having served for many years as the Vice President for Scientific Affairs at Eli Lilly. Could you offer your take on what do we really need to do in terms of research to advance this cause? And secondly, how do you see the way forward for industry and government and professions to work more in concert toward the learning health system, the patient-centered system, the effective care system that others have been talking about so far?
Thank you very much, Harvey. What I would hope is that we would all appreciate the fact that science and research are essential to a learning health care system. In fact, if you look at the diagram in the report of what constitutes a learning health care system, it's science first. So the research investigators, whether they be working in an academic environment, in an industry environment, or in our federal agencies, like in the FDA, they must be equipped with the very latest in knowledge, appropriate investment to continue the research engine that has brought about the tremendous advances in the practice of medicine that we have today. We cannot slip backwards. We must, in fact, continue to invest in each of the sectors, the public, the private, and to ensure that the federal agencies like the FDA have the adequate resources to stay up with the science. So that's first and foremost. We've had major advances based on this investment in science over the past decade. Perhaps we've not invested as heavily as we should, in which the report actually points out, in newer methods such as analytical tools to improve our capabilities in data mining and also in transferring the information that we generate in the laboratory or that we generate concerning new therapies, new treatments, to translate that information and that data into improved patient care. So what do I mean by that? I mean we need to invest more in developing those analytical tools, to look hard at the design of clinical trials, to determine how we can reduce the cost and improve the efficiency, and also increase the speed with which the clinical trials are conducted. And there are, as you know, several activities within the Institute of Medicine right now focused on this. So that's first and foremost. I think it is a major problem for each of the sectors, quite honestly, in terms of translating the knowledge that we do have into actual changes of public policy and, more importantly, practice of medicine. In the report, we give several examples of this. Maybe I could share one of my own, and that is that when Group B streptococcus was first identified as a major cause of pneumonia and death because of bloodstream infection in newborns, and the data were solid. Nobody doubted the data had been reproduced in multiple labs. It still took 10 to 15 years before, in fact, routine screening in the hospital clinical microbiology laboratories or the physicians requesting the screens be done before, in fact, the practice was changed to do this in order to save the lives. So we have to figure out how best to translate and get to those practicing medicine this new knowledge and how we develop practice guidelines. This brings us to the question that you ask, and that is really how do the scientists in industry work better with government and also with academia. And I think that the biggest challenge for each of those groups is not only better communication and interaction and synergy between all the sectors, but again, how best to put new knowledge and information into practice in the most efficient and safest way for safety of patients. As you know, new guidelines have been put in place over the past 5 years in particular that deal with conflict of interest. And this is a major issue, still continues to be worked on in the Institute of Medicine and in all of the federal agencies. There's a very delicate balance between avoiding those conflicts of interest, but being certain that the knowledge that needs to be transmitted from the private sector, the public sector, between the private sector, the FDA, other regulatory authorities, et cetera, is exchanged in a very efficient way. It's a costly process, continuing medical education, and we, I think, still haven't quite figured out from that standpoint how is the best way to do this and how can the investigators working in industry best communicate and interact with those in academia and also in government.
Thank you very much, Gail. Before we turn back to the audience for questions, I'd like to come back, Mark, to you, returning to one of the central points you started with on the 4 foundational characteristics, 2 of them particularly that you mentioned. I wonder if you could elaborate on. One was incentives, and the other was culture. Could you say a little more about what incentives to whom, expressed in what way, and what does the committee mean by the cultural element? Is it just an organization? Is it the culture of medicine as a whole? Is it the culture of American society? What parts of culture really are critical here in thinking about moving toward a learning health system that delivers best care at lower cost?
Okay. So culture of America as a whole is above my pay grade. I don't think the committee. But I think there is kind of a cultural shift that has to happen both among providers and patients, frankly, about who's responsible for what. So I think there's a little, sometimes I think lay people get a disconnect when they hear people like the Institute of Medicine use phrases like the system is broken and things need to be fundamentally changed, because they know that the truth is that in some ways American medicine is the best the world has ever seen. And we do things every day that are exceptional, that are almost miraculous. I'm an AIDS doc. No one is more aware than I of how much progress we've made and how extraordinary our ability is in some areas. And yet, alongside that, which people are aware of, they also have their own experience, which almost always falls short of their aspirations, and we have the hard data that we've all looked at. So on some level, we're talking about both clinicians being reoriented in part through financial incentives away from doing the thing that I'm trained to do and that I get paid to do, whether that's doing an operation or seeing a patient in my office or doing a procedure, to what services do need to be deployed for this patient to be as healthy as possible, as affordably as possible. And so that cultural change from episodic, volume-based, cost-agnostic to longitudinal, outcome-based, cost-aware is a culture that, for better or worse, both patients and clinicians need to absorb and adopt and change their outlook on. And that culture inside organizations, I've been in the last year to places like Appleton, Wisconsin, to Theta Care and to Denver Health. And when you see organizations that have really adopted that philosophical change, with everybody from top to bottom is kind of working on the same page, it's quite dramatic, the changes that can happen.
Yeah, great. Thank you so much, Mark. Let me now invite members of the audience to please indicate if you'd like to pose a question. We have microphones that will find you. There's a questioner in the back, so please identify yourself and offer your question, please.
My name is Joanna Kaufman. I work for the Institute for Patient and Family-Centered Care, and thank you all so much for the chapter in engaging patients and families as part of the solution to this problem. My question has to do with spread. It goes back to what you're talking about. How is it that culture and patient engagement can really happen where the rubber hits the road, where you're talking about nurses and physicians and hospital systems? Do you have any practical suggestions, and how are we going to get this out to all the hospitals across the country that this is important?
Thank you very much. So how does the conversion happen in practice, and how do you get it disseminated everywhere? I wonder, Bruce, you've had experience with these issues directly in delivery of care. Do you have thoughts about what it takes to make this happen?
Well, we deliberated actually a number of times at the committee level as to could we prioritize the responsibility of making this process happen. And I think legitimately we came to the conclusion that it took everybody involved in healthcare to get us where we are, and it's going to take everybody involved in healthcare to get us where we need to be, without singling out an entity or singling out some type of priority. What that means is every component needs to do its own tasks and be cognizant of the tasks that the other components are doing to try and achieve it. And there are wonderful examples out there. And perhaps the challenge is to, as indicated in the report, really understand what those examples are, and then for health systems or communities or environments or individual practitioners to look and see how they would change the way they practice health care based on those examples and based on the construct that's in the report. And I think we all have to assume individual and collective responsibility for turning this ship around and getting it organized and structured in the right way and pointed in the right direction.
Well, thanks. Craig, would you like to add a word on this?
I think it's a really important question, and there are clear examples around the country where you see the changes that are called for in the report taking place. And just practically, you have to have the strong leadership, the will, the commitment to pull a bunch of different interests together and begin toward this march toward a new culture that Mark was talking about. And then inherently, I think many clinicians, maybe most, would say they went into what they did so they could help people, and they wish they could work in an environment where they had the time and the team and the people to do the most thorough, high-quality job they could. So then you need the payment reforms to let that come alive, the incentives that will allow teams to work together. And practically, if you really look at the report and look at the set of recommendations, if you walk through all those recommendations, they all have to come in parallel almost, or in some very close sequence, to allow these reforms to scale. But they already are starting, and it can occur. There are good examples. And in the end, again, just to emphasize, the ability for a team of people to help patients and families, and where the family or the team or the patient is actually part of the team, that is a profound mark of culture change. It actually, when you see it happen, it's a profound culture change. And that can occur, and I think the recommendations in the report are almost in some sense a roadmap of the things, some of the things that have to take place for that to occur.
Thank you very much. Mark, would you add a word?
Yeah, part of the way things spread in healthcare is that people can actually see it and touch it with their own hands. And so part of why I think this committee's report is fundamentally optimistic is because we see this change beginning to happen. Places like Denver Health, Virginia Mason, Theta Care have now had to set up tour operations, essentially, to handle the demand of hospital leaders and system leaders from around the country who want to come see it for themselves. And that's a profoundly encouraging notion, because for better or worse, that's part of how spread happens, is people see something that they did not know could exist, and they come back inspired. And the fact that this is now building to that level of demand is part of what makes us optimistic that this vision we have is not a hallucination. We're seeing early signs of it going on, and we're trying to highlight those examples to encourage others to spread them.
Thank you very much. Before we turn to another questioner here, if I may, I'd like to introduce a question that came from our web-based audience. This is from Jim Landers at the Dallas Morning News. And he's raising a question that goes back to the early point about complexity. He says, if the system is stretching the cognitive capacity of physicians, what does a solution look like? Is it a handheld pad that the doctor uses to find references for diagnosis, therapies, and such? Does it warn doctors away from approaches that they might take? What does it actually look like in practice? Rita, do you want to comment on that?
Sure, and of course, there's not one simple answer, but you know, as we outlined in the report, a lot of it is using the computational and the connectivity. So there are clinical decision support tools now that are available, that are easily available in the electronic health record. But there's also, I mean, it's different, I think, for every patient-physician interaction, and a lot of it is I think, having more time to actually talk to patients, to go through risks and benefits with patients. You know, there are times I'll say to a patient in the office, you know, with a particularly complex question, I'll say, this is what I know right now. You know, this is my best advice, but I'll talk to some colleagues, I'll look it up, you know, you can think about it, and then we'll talk again next week. I mean, I don't think it's not going to be the same answer for everything, but I think a lot of it is also about changing the incentives in the system, and so it's not, we don't have the urgency to have quick action, quick treatment, you know, write a prescription or order a test for every patient-physician interaction, which is what is most highly valued in our current system, and that I think we have to have a lot more just thoughtful conversations. It's often true that when patients understand risks and benefits of procedures and treatments that we offer, they often choose on their own more conservative treatments and less procedures and less. And the problem is that we often are not taking the time for lots of different reasons to have those kind of conversations. So a lot of it is really having more patient-centered time and more time for conversations, as well as the backup of the clinical decision support. And I think there are a lot of movements currently in the profession for us to be better stewards of healthcare and to really be a lot more thoughtful and take the time to go through risks and benefits before moving ahead with procedures.
Thank you, Rita. Bruce, do you want to add a word on this?
Just an additional comment that maybe an example of the inherent opportunity there is that when we were all in medical school, we spent hours in the library Xeroxing papers that we had been sent to by our mentors. And I don't know when medical students today ever even go to the library anymore, because everything's available online. Our challenge is to figure out how to collect and use that information in as close to real time as possible so that the connectivity between that science and the care that we're delivering is as short and as effective as possible.
Thank you very much. I'm going to turn now, if I may, to our next questioner here. I think we have time for just 2 more questions. We'll take this question and then another, and I'll ask the panel, if you could, to be as succinct as possible in your responses, as well as, if I may, the questioners. Please.
Thank you, Dr. Feinberg. I'm Peggy Eastman with Oncology Times. Dr. Redberg, you alluded to the new technologies that are coming on apace. We're now in the era of targeted therapies and personalized medicine. So I'd like to ask the panel, how do we as a society and as a healthcare system address therapies that are hugely expensive and may only give 4 to 5 months of increased life, which often occurs in advanced cancer?
Who would like to begin? Rita, would you want to comment on this as well?
Sure, and I think that's a tough, certainly that is a tricky issue, and we can look at the big picture, but I always, as I said, start with the science, and a lot of the challenge is identifying the group. So if there is a therapy, and I think we're still right now working on personalized medicine. I mean, the more I learn and study about genetics, including today's paper, which said, talking about the junk genes, which, was 97% of DNA, and there's trillions of nucleotides, and this actually seems to be important. And the message to me is, I think we can get to personalized medicine, but it's, I think, a long time before clinical use. So then the question is, is it overall the benefit? I mean, it gets into a lot of very complex scientific issues on the clinical trial and the importance of the data. And so I would just go back to, was it a randomized clinical trial? Was it blinded? Was the population similar to the population you want to apply it to? Because when you're talking, and then what drives the cost of therapies? Because there are some incredibly expensive therapies, and some of them I think it's hard to justify how costs of some of the therapies based on just the research alone. So I think firstly, we want to be sure they're truly, life-saving, because it's often not quite as simple as that. It may be a very small population that will benefit and a large one that won't. So I think we get back to the science, and then we get into big picture and allocation and priorities.
If I could ask Gail and maybe Craig to comment very briefly as well, because it is an important question too.
Just quickly, remember the science is complex, and while today that advanced personalized therapy may only result in 5 months of increased life, in 5 years' time it may be years and not measured in months. So we have to take small steps. If we don't take the 1 month at a time or 5 months at a time, we're not likely to get to that therapy in the end that will, in fact, result in increased years of life. So I think we all have to remind ourselves of that, and it may not be cheap, right? Science is complex and costly these days, as are complex therapies.
Thanks, Gail. Craig, did you want to add a word on this as well?
Really briefly, I think also this goes to the heart of the focus on patients and their wishes and desires. And right now, with better coordination and team approach, patients, families could be more informed about what really is the meaning of a certain treatment, what really is going to happen, what's the likely outcomes, also maybe what some of the difficulties would be undergoing that treatment, and what's that 4 or 5 months really going to look like. And so giving the information that helps them make better decisions is something we probably could do in the near term. The longer term would be to get at the heart maybe of what you're asking and begin to have computational power that could look back over larger populations and look at experience and predict which people are likely to gain more time, which are likely to gain less, which people are likely to have adverse reactions, which are less, and make this informed decision more informed. And so that's the vision, but I think in the end it comes down to giving families and patients the chance to have their wishes really addressed with the best information we have.
Thank you. Is this going to be a brief question, because we're a little over our time, actually? So please take the mic, identify yourself, and pose the question.
Hi, sure. Richard Singerman, and I sit on the Digital Learning Collaborative for this Science and Value-Driven Roundtable. It's really kind of a combined question, but I'll try and keep it really brief. First of all, as you talk about the new vision, these are very different skill sets. As I recall an article, I think it was written by Dr. Pronovost at Hopkins, physicians in med school are usually not trained in quality improvement. These come much later after all the other things that they quote unquote learn, they get tested on, and they don't use. And so it seems fundamental to our knowledge explosion is really a pretty fundamental shift in what really should the physician and the nurse know in the 21st century, because this is a very different skill set. And then secondly, because I think it's just so important, we have the benchmark institutions, the Kaisers, the VAs, the Geisingers, and each of those cases we see integrated payers and providers. And so we kind of have models of what's really working. And are these other kinds of payment reform mechanisms, ACOs, patient medical homes, just really kind of artifices to get us there for those places that already work? So I know that was two, but sorry.
Okay. I'm going to stipulate that the first is a comment, not a question. I think everyone would agree it has profound educational implications. But let me ask, does anyone in the panel want to comment on the second part, particularly? Mark, would you offer a
I think
response?
you'll see throughout this report an emphasis on organization. Modern medicine is a team sport. But we also are quite clear that not every physician is going to be in the same kind of organization, and in the same way that we have tools that allow patients to communicate with physicians, physicians with patients that didn't exist 20 years ago, we have tools to tie physicians together in virtual groups to create relationships between physicians and other providers in the community that didn't exist when the Permanente Medical Group was formed. So our view, I think, is that there will continue to be different forms of organization in different communities, in part because of the infrastructure of those communities, in part because of physician choice. People will be in organizations, but there may be quite a wide variety of organizations, again, using modern technology to do some of the things that 30 years ago you had to use co-location and joint membership to get done. And a lot of the work that Craig is doing is an example of those kinds of things.
And that work, I know, is illustrated throughout the report. And I do want to say that we know that there are many, many critical facets to this very complex problem. I believe that the committee has produced what will be regarded as a landmark document, a guidepost that pulls together abundantly the evidence, focuses it, and points the way to a clear path forward. And I just want to again express my deep appreciation, Mark, for your leadership, to everyone here and to every member of the committee who labored on this report to help us get the clarity, the focus, and the direction that your report provides. We are committed through the work of the Value and Science-Driven Roundtable at the Institute of Medicine to continue to work to implement, to extend, to get adoption, and to disseminate widely the ideas, the changes that the report calls for. And in that way, we are all going to be working toward a health system that does provide best care at lower cost. Please join me in thanking the panel, and I thank all of you for being here.